So, so I'll go ahead with my PPT over here. So, with the improvement in surgical techniques and constant evolution of technology, primary vitrectomy in RD is the treatment of choice in most cases. However, individual surgical variations are abound. Some prefer 36 degrees laser, some don't. Some prefer PFCL, some don't. And some prefer belt buckle, and some don't. But likewise, me and my senior here are debating about peeling of the eyelid in primary vitrectomy for retinal detachment. At the outset, I would like to say that every treatment variation, in our case the surgical, is right as long as the patient is benefited. However, we need to gauge or balance what is right for the patient, as he rightly said. So, coming to the basics, indications of ILM peeling in VR surgery are a few: macular holes, epiretinal membranes, macular edema, myopic macular retinoschisis, retinal detachment. So, I have been blamed of talking about chromophore toxicity, phototoxicity, damage to Muller cells. Well, yes, they are there. Indocyanin green, we all know, has an affinity for laminin and collagen type 4, and we all know that it has been documented side effects like field losses, multifocal ERG changes, thinning of the retina, that is structural, and we cannot get rid of that. Reduced enzymatic transmission, it is a biochemical change, and it is going to be permanent. So, but then these are dose-related effects, osmolarity-related or photooxidative quality of the compound causing cellular damage. And these damages at the cellular level are going to be permanent. Trypan blue, yes, but then this needs to be diluted, needs to be used after posterior highlight removal and after doing a fluid exchange. It does have neurotoxic effects on the ganglion cells, and by chance, if it has entry to the subretinal space, it can cause RPE degeneration as well. These are again dose and time dependent. So longer the duration of trypan blue staying inside the eye or on top of the retina, more are the chances of it causing damages. So as has been told, chromophore toxicity is there. Triamcinolone acetonite, another one of the favorite medications which we use for ERM or ILM peeling. The crystals adhere to the vitreous, ERM and ILM. It does not have a well-proven but can cause effects similar to the ICG. Delays healing, especially in macular holes. Again, they say this is controversial. But then what I have always thought of is crystals of this very triamcinolone can cause direct physical damage to the retina if PFCL is being used, and these crystals sometimes are so adherent to the ILM that they don't come off. Phototoxicity, yes, we all know photothermal, prolonged exposure to light. Sometimes we have to hold the light pipe very close to the retina to have a peel. Photochemical, due to excitation of endogenous chromophores like photoreceptor pigments, RP pigments, or exogenous chromophores like ICG. These cause reactive oxygen species causing cell damage, again a permanent damage to the retina. Damage to the Muller cells, again I was blamed that I would be talking about this, but yes, these are definitely caused when we do ILM peel because Muller cells are closely associated with the ILM. And microscopy has shown that Muller cells have been peeled off along with the ILM tissue. These in the long run may cause paracentral holes and paracentral microscotomas due to reduction in retinal sensitivity. This definitely needs expertise to reduce trauma to the macula. These are surgeon-related issues in ILM peeling. When we use PFCL to flatten the retina, commonly when we are doing the pinch and peel technique, the flap tends to fall back because of the weight of the PFCL pushing it down, and then we have to again try to catch hold of the ILM. And every time that we are trying to catch hold of the ILM, it may cause some amount of injury to the surface of the retina. And if we are confident enough, we can do without the PFCL. And but then it is very difficult as there is no counter traction. In this case, we were trying to do a removal of the PVR membranes, And then as we try to induce, start the ILM peel after injecting blue, BBG, the ILM peeling becomes very difficult with the pinch and peel. Invariably, we'll end up doing some injury to the retina again. So then why to peel the ILM prophylactically in every primary vitrectomy for retinal detachment? This is my question to Pawan sir as well. But then there need to be specific indications. In my case, peeling is not indicated in fresh RD without any PVR changes at all. Or when we are planning for a gas tamponade. Or if the surgeon is novice. I know I am not a novice, but then I wouldn't want to cause injury to the retina just for the sake of removing it prophylactically. Peeling definitely is indicated in PVR changes, vitreous hemorrhage, RD associated with macular hole. When we are planning for silicone oil tamponade, there are larger breaks or giant retinal tears, or if it is a combined or recurrent retinal detachment. Thank you.